We're talking today about a paper that you presented at ASCO, really looking at trying to extract extra value, I would say, from the randomized data we've had out in the world before. So this was based on the ARAMIS trial, which, just as a quick level set, was a study of treatment intensification for patients with nmCRPC, so the addition of darolutamide to the ongoing androgen deprivation therapy for patients with nmCRPC, high-risk nmCRPC. And can you really highlight what the sort of goals of this post-hoc analysis were and what additional information we're trying to gain?
Sure. And as you said, just to emphasize what the ARAMIS trial was, this was an important trial. It was a registration trial. It led to the approval of darolutamide in the non-metastatic castration-resistant setting. It really demonstrated that when ADT was intensified with darolutamide, there was a 22-month prolongation in metastasis-free survival versus ADT alone in this high-risk non-metastatic castration-resistant prostate cancer setting. Obviously, castration-resistant non-metastatic disease is a state that we as treatment-providing clinicians actually induce. So important that this is not a hormone-sensitive biochemical recurrent situation, which is something that's also been in conversation recently related to the EMBARK data, which is obviously separate. So this was really an assessment of the ARAMIS data to try to understand if we could continue to pull some bits of information so that we could use it in clinical practice. And I would say a non-metastatic patient population in this setting includes patients who were non-metastatic, had no radiographic evidence of metastatic disease on standard CT scans and bone scans. Perhaps some of them may have had MRIs, but I mean, these were really what we would think of as conventional imaging strategies. So these patients probably had PSMA PET scans that were positive, but these patients actually didn't have access to PSMA PET scans because the trial was run actually many years ago. And of course, as I said, sort of reported out in the 2019, 2020 sort of timeframe and led to that approval. So, I think when I consider this, I think, and we were fortunate to actually have you participate in this analysis as well, as a urologist and someone who's really good at some of these additional analyses. We tried to sort of understand what could we learn from this data that might help us in clinical practice. So one of the things that we were so curious about was understanding the way that patients may progress so that we make sure that we as clinicians are not missing progression events, especially missing them such that they're identified clinically by pain or some other symptom, because we do know that patients who actually present with pain at a progression event will do worse than if we can catch those patients at an earlier time point. And so we thought about that. And then we also thought about, is there a difference perhaps by patients who respond really fully and quite completely with a PSA that is less than 0.2, a threshold of detectable in the settings where this study was determined. This is not necessarily the ultra-sensitive, undetectable that we can do in the US in some centers, but really more of because this is an international trial, a sort of more broad definition of what is undetectable. So less than 0.2 versus greater than that amount for PSA response. Does that sort of impact how patients may have a duration of response to treatment and also impact the way that they progress when they have that event?
Absolutely. And I think it's, has different messages for different clinicians because of how we practice. And I think that notion of how patients progress is really important. We think about, how we want to monitor patients. So maybe, walk us through the difference between, a PSA-based endpoint, a radiographic-based assessment, and how it looks like the intervention affects maybe the distribution of progression events.
Sure. So a PSA endpoint in prostate cancer has notoriously been a little bit fraught. So this can be an endpoint that may be not necessarily tied to some harder and very important endpoints like overall survival in particular. And so I think over decades of research in prostate cancer care, we have not necessarily relied as strongly on PSA progression as being something that is going to be so meaningful in terms of disease control, though of course meaningful from a patient perspective and actually of course meaningful from a clinician perspective, because sometimes PSA progression does induce clinicians to do something different. What was used as a primary endpoint in this trial was metastasis-free survival, so conventional imaging radiographic progression. And I think that is something that was really part of the focus for this additional analysis. What we looked at was the different arms of treatment. So those patients treated with darolutamide and those patients who were treated with placebo, and both, of course, both arms got ADT. And we found that it did not look like those patients who had a more intensive strategy of hormone suppression or blockade, those patients treated with darolutamide, they did not have more sort of atypical progression. And I think this is something we were thinking about, with atypical progression, and in my mind at least, being defined as radiographic progression without PSA progression. Usually we're going to see PSA rising before we see conventional imaging that demonstrates that change. And in this case, those patients in the darolutamide had a radiographic progression that was sort of prior to PSA progression of about 4.2%, versus those patients in the placebo arm, it was about 5%. So more intensive androgen blockade did not cause atypical progression that could perhaps be concerning, because we might be more likely to miss that. We did see that a majority of patients who did have progression events seemed to have PSA first, and then those patients who kind of met the endpoint of having MFS with a PSA rising as well were the next most common group, actually in both arms. Of course, also in the placebo arm, there were more events overall, and this makes sense because obviously ADT plus placebo was inferior in terms of cancer control as compared to ADT and darolutamide.
Absolutely. And I think it's reassuring that we're not getting these atypical events. I do think it is important for the urologist audience to think about the fact that they are occurring. I think in the, in the hormone sensitive space, we really depend on PSA monitoring to trigger for-cause imaging. And I think as we move into the castrate-resistant space, that decoupling does happen. And even though we're showing it's relatively infrequent here, it does occur. And so the notion of scheduled rather than for-cause imaging, I think, is an important idea in this disease space, and probably all others with castration resistance. And I think that is probably something that's well known to a med-onc audience, but maybe a little less familiar to a urology audience, because in that castration sensitive space, I think we can typically count on a PSA response to guide us for disease progression.
So one thing I would say is that don't underestimate the knowledge base of urologists or overestimate the knowledge base of medical oncologists, because I think that for both of our groups, this idea of temporally based imaging as a backup to cause-directed imaging is not necessarily something that we've standardly considered. Although I would say, to their credit, the NCCN has adjusted the guidelines, at least in the last couple of years, to suggest for a metastatic hormone-sensitive prostate cancer population, we should consider, even without PSA progression, imaging at a 6 to 12 month time point in that setting. And I remember back when I was in training, well before you were in training or probably even knowing that you wanted to be a doctor, but at that time we would start hormonal therapy and we just followed. We didn't even normally get testosterone levels, to be honest, but we just followed the PSA and symptoms until that patient had progression, which could be, especially for some more indolent metastatic disease or maybe less aggressive metastatic disease, I should say, we could follow them for over a year, 2 years even, depending on how they responded. So the NCCN, I think, has recognized this. There's been increasing data that we need to take care of this and do it in, I think, all settings. So the way I read this too is very similar. There are progression events that are happening. At a minimum, think about scanning these patients, even though they are classically non-metastatic, somewhere around every 6 to 12 months, with 12 months really being the maximum there. One other thing, though, that just to comment is that we are not necessarily using conventional imaging strategies in this situation anymore. We're really using PSMA PET. And I think that can be challenging in a situation where we don't have PSA progression, because we wouldn't necessarily expect there to be a high level of PSMA expression available for us to identify on a PSMA PET. I think in those patients who have suboptimal response with a PSA that never gets below 0.2, this may be more easy and actually would be a preferred strategy from my perspective in terms of imaging, though of course that's not based on data. That's just, a preference that I'm voicing. But especially for patients who get to a PSA of less than 0.2, I would worry a little bit about kind of using my PET scan up and then not being able to get another one for a prolonged period of time, even with PSA rise, if I was doing it with that PSA still being less than 0.2. And actually a fair number of insurers in the United States would not approve of a PSMA PET with a PSA that's so low.
Right. We're lucky. Where I am, we can get PSMA over 0.1. And we get a 6-month renewal. So you can't do it within 6 months of the last one, but as long as you've exceeded 6 months, you can typically get away with it. But you alluded to this, 0.2 cutoff, and I think that was another part of the presentation, and really that sustained deep response. And maybe walk us through what you think that means for a patient prognostically in clinic, and how we use these data to help inform our patients.
Sure. So when we do have patients who get to that less than 0.2 threshold, which again is sort of trying to be an international standard for undetectable PSA, we saw that even at 3 years, the risk of metastasis was still under 9%. It was 8.7% through follow-up in this data set. But for patients who had a PSA that was greater than or equal to 0.2, we saw that recurrence rate was about 50% at the 3 years, with a relatively just stable increase over time. So I think, clearly these are different patient populations. Clearly they're being affected more or less thoroughly by this treatment. And I think those patients who really don't get to that less than 0.2 threshold are patients where we are going to want as clinicians to have a closer eye on this population, because by 3 years, half of them will have a metastasis event. And this is on, again, conventional radiographic imaging within the ARAMIS trial. And so this is a patient population at risk, and one that we need to be really cautious about. The other thing I would say, in this trial, obviously more patients who were treated with darolutamide got to that PSA threshold or point of less than 0.2. So as we're treating this patient population, we also want to make sure that we don't miss the opportunity to intensify with systemic therapy to achieve that really robust and pronounced PSA response, so that we can have hopefully more durable disease control and avoid that high risk of progression.
Got it. And maybe it's a bit unfair question, but the trial doesn't get us there. But what do you think about the idea of changing or intensifying therapy based on failing to meet PSA nadirs? Or do we just know that this is a high-risk patient population we need to watch a bit closer? Or can we actually intervene based on that lack of low nadir?
Yeah, such a good question, and actually a question that we see in metastatic hormone-sensitive disease and nmCRPC, in addition to nmCRPC, like in this trial. I think right now, this identifies a patient population with a suboptimal response that we, as clinical trialists and clinicians interested in research, need to pull out and design clinical trials to try to address. But at present, it does not provide sufficient data to change our treatment strategy. And I mean, as I think about it, Chris, I'm not actually even sure what I would use to intensify, because I'm sure we could come up with things. I'm sure there are agents that are in the pipeline that you and I would be happy to design a clinical trial. But just among available agents here, I would not be pulling chemotherapy as a next play here. And I think that things like radiopharmaceuticals would be potentially of high interest, but obviously we need clinical trials. And for other agents, we need clinical trials to try to understand that better.
Absolutely. And I think, as we try and put this in context, nmCRPC, as you alluded to at the beginning, is sort of an iatrogenic disease state, and probably shrinking both with our, intensification early, as well as our use of PSMA PET to find radiographic evidence of disease. But I think in spite of that, we've been able to get some pretty useful practice pearls out of these data that maybe less affect our treatment decisions and more help us shape the way we think about taking care of these patients. So I really want to thank you for taking the time and chatting with us today. And hopefully I'll see you for a heavy prostate session at ESMO this fall.